So if you want to use the screws, you should have a good quality of the bone, and then you should have a uniform sort of surface for compression. And then you are not sure how many screws are adequate, two, three, or four. Look, this is the talus is something like trapezoid. If you don't have a good surface for uniform compression with the screws, you may not get the arthroscopic, the arthrodesis. And in cases like this, there is hardly anything there for minimally invasive procedure. Coming to screws, there are number of constructs available, two anterior, one posterior, and then just two going from the medial side, then cross screws. Whatever works with you is fine, but the most important is you should have a good compression, you should have a good purchase, you should well prepare it, and then it is important. But what, let's see, this is what happens as you keep on adding these screws, the surface area for the fusion keeps on decreasing. So if you see more number of screws you have, the surface area for the fusion is very less. And this is where I feel the interior plate augmentation for ankle arthrodesis helps. And you see, this augmentation increases the stiffness factor by 3.5 in sagittal plane, and then again in axial plane, and then it resists the torsion movements, and then it counters the cantilever bending forces in the sagittal plane. And 96% union in 275 ankle arthrodesis with non-locking anterior plates have been reported. This is another study where they say the what actually the compression is, how much compression is there, and as we go towards the plate, you see there is more and more compression can be achieved. This, I think, there are number of plates available here, but our concern with this is availability, price, and affordability of the patient. So that is why probably we are scared to use plates in our scenario. But let's see what this is. One where a simple, a plate, DCP has been used with 100% union in 29% patients. This is another where you see just a locking recon plate has been used. So I take you how I do it, and how does the simple way of I'm showing the cases where how I use just a simple lower end radius and the proximal humerus plates for this. Look, this is really, you cannot, I cannot think of doing arthrodesis, ankle arthrodesis through arthroscopy. And you see, we just use the simple lower and radius plates and the screws, and we could achieve the arthrodesis. Another where we use two plates. Again, lower and radius plates, one on the anterior and one on the lateral side, and we use the transfibular approach to correct this, and we could achieve the union. Look at it. It may look that it is not this patient may be very easy to do it, but when you look at MRI, the whole this bone is gone. Imagine you should be prepared to fill this bone. So we went ahead and did again an arthrodesis with a just a radial plate and just screws. This is another patient, a compound patient. Then actually there was a big defect. It was for done for the talus. Somehow this defect need a coverage with the. Ultimately, the patient developed arthritis, and we just went through the flap through this approach, and we could achieve just a union with just simple radius plate and the calcaneus. This is another patient who had an infection, and we told him that we want to correct this deformity. He said he is not at all interested in doing anything, and it was difficult to put an anterior plate in this. So we just used a humeral plate, and the patient was happy. We could achieve the union. This is another patient where we have just used a transfibular approach, and you can see just a simple upper and humerus plate, and look, we could get the union. This is another case. We went ahead and we used plates from all the three sides, and we could get the union with just plating and bone grafting. But one thing is certain, that whatever the technique is you are using, you need to avoid this equinus. And this is one patient. It was done by us only, I would say. If you see here, right from the beginning, your talus has translated anteriorly, and when we followed this patient, we again had the anterior translation. Fortunately, it went on to union. But this is, I have shown that just we need to avoid, number one, the translation, and we need to avoid this plantar flexed talus when we are doing an open arthrodesis. Okay, this is another. You see, tibio calcaneal arthrodesis was attempted. It failed, and we used this plate, and we could achieve the union and upper and transfibular approach, and we just went with a simple. This is another AVN, and when we opened, the whole bone was lost here. Actually, we had to remove. And see, we used two plates, one on the humerus and the again on the this is the radial plate, and then we added a fibular graft here along with it. We took a fibula, whatever it is, and we just shoved it from the calcaneus right into the tibia, and we could use the. And finally, this is one case, you see, where we had a compound fracture. Again, it needed to cover of the talus, and unfortunately, this patient developed arthritis infection. Then we did and removed everything, and then after that, again, I know this is a little prominent graft in this, but still we could, after that, through the transfibular approach, we could use. And this is one of the patients who had a just a stiff cavo equinus deformity, a young female of just 26, and she wanted just a plantigrade foot, and we extended our the arthrodesis from ankle to subtalar to pantalar, and we could still achieve union with all these very commonly and cheap plates. So conclude, I would like to conclude that arthrodesis with the plate is an effective technique, and it is particularly useful in the presence of deformity in the bone loss and the poor bone quality. And you can just use the simple plates, which you don't have to get a very high fancy. I can understand that there must be people who saying that the union rates are definitely better than these conventional plates. But you see what is available to your setting, and the difference is only 4 to 5%, not much. If you use these plates and you prepare your joint surfaces well, do an adequate bone grafting, put your position right, then you can have even a good union of arthrodesis with simple plates. Thank you very much.
Thank you, Rajiv Vora, sir. And that was an excellent presentation. You have just put the right tone of the webinar. There were certain some beautiful cases which were done with simple implants such as humeral plate, which
So
are
should I stop sharing?
yes, sir, please, because the
Okay.
next up is
Yeah.
Dr. Vinod Kumar
Okay.
Panchavavi from USA, Galveston, Texas, who would be speaking on TTC nail. Vinod, sir, you can start your screen sharing now.
Sure. I just,
So,
there you are. Got it. Hope you can all see my screen now.
yes, we can.
There was an excellent presentation, Dr. Vora Saab. You've shown some very challenging cases over there. Very interesting. I want to thank Dr. Shantanu Anand Kumar and the IFS for the opportunity. For my presentation, I'm going to be talking about TTC nail, and I will not show much of the current literature, but I'm going to share some of the tips and techniques which I have over the years come across or developed. So let me maximize the screen here.
Yes.
Okay. All right. So here we go. These are my disclosures. Nothing that would present itself as a conflict. I might show some nails from these companies. I'm editor in chief for the techniques in foot and ankle surgery. If you haven't had a chance to look at this journal, I would encourage you to do so. And also, if you have a new technique or emerging technique, I encourage you to submit those techniques to this journal. So these are the lateral views of two different patients. One is having a congenital severe deformity, and the other one has a diabetes, Charcot neuroarthropathy. You can see that the hind foot is has a severe deformity with the talus almost touching the ground and the foot on the lateral to the tibia. So these are not the kind of cases you want to start off with. I know we are addressing this webinar to some folks who are doing general orthopedics or who may occasionally dabble in foot and ankle surgery, but these are, although these deformities can be managed with a nail, I wouldn't suggest that these should be the first ones you should try. Certainly you can nail these things, but I would strongly recommend you start off with easy ones. So certainly the nail is a powerful implant and a good technique, provides stabilization, and you can get a reduction and stabilization of the hind foot to achieve success. If you don't do it right, there are potential for problems, just like Dr. Rajiv Vora has shown some of his cases, wherein if you plantar flex the hind foot, leave it fused with plantar flexion or excessive dorsiflexion, there can be problems. I will show you the problems can exist in other planes as well. So here is an example wherein the hind foot is plantar flexed and also subluxed forwards. Okay, and here is another example wherein the foot is dorsiflexed and subluxed forwards. So when I say subluxed forwards, what I want to make sure the folks understand is the entire foot in relationship to the tibia. So it is subluxed forwards. So here is the problem. So you can see that the heel is not touching the floor, right? So luckily he lives in Texas and he has these cowboy boots and he can manage to use these boots with the heel and he's coping. Okay, so but that's a problem. You need to have a heel underneath to kind of get by. So what's going on here? See, so you can see if you look at the hind foot, there is a varus angulation. You may think, so what? But this guy is a farmer and he cannot get by unless he wears this big AFO. So he has got this double upright AFO with a leather gauntlet here. And in addition, he is wearing this total contact insert. And notice what's happening here. See, so he has made a recession there because that's where he's getting a recurrent callus under the fifth metatarsal. All that is because somebody has fused his hind foot in degree of varus. So if you do not fuse, if you do not get the position right, you could get the fusion, but you may leave the patient with iatrogenic deformities, which can be troublesome. So I'm going to go over some technical tips, focusing on how I do these things. And here is, you start the positioning of the patient. You need to make sure that you have adequate support. You see the other leg is away, so you don't interfere with radiographs. So you have to have some kind of a bolster, radiolucent, obviously, for x-rays. And you need to have a C-arm, preferably with a with a laser pointer, so you minimize on the takes. And the important thing is that you should be able to use the hip rotation to get a good axial view. So you need to absolutely make sure that you are able to see the tibiocalcaneal alignment view. As you can see in these fluoroscopic shots, you should be able to see the lateral image and also a good Harris view or tibiocalcaneal alignment view. Very important. You must be able to see the sustentacular tali portion on this side and ensure that the nail has calcaneus or the reamers or the guide pin which you have as a starting point should be on either side. You should see bone on either side of the entry point. Very often you might think you have a right entry point, but you're entering into the sustentacular tali or the medial wall of the calcaneus. Certainly you can do this nailing in a lateral position, but you can also use a prone position to do this. Just like Dr. Rajiv Vora mentioned, you could use the prone position for ankle arthrodesis. You can certainly use a prone position for getting into both the talus and the subtalar joint. So the ankle joint and the subtalar joint. Especially if the patient has got an equinus contracture, you can use this approach. You can do a Z lengthening and move the tendo-Achilles fibers apart, and then you have a great view of the posterior aspect of the subtalar joint and also the ankle joint throughout. So you kind of you're killing two birds with one stone. I make a big deal about this anteriorly subluxed foot because you see what's happening. You increase the lever arm and also increase the chances of arthritis in the show part joint, talonavicular and calcaneocubar joint, and sometimes even the Lisfranc joint area. So you can see how anteriorly subluxed this foot is. So you kind of increasing the lever arm. It is like as if you are walking with your skis on. This is my family in Colorado. It does make a job easier for you to drop the nail because you'll be capturing a wider part of the calcaneus. But you will leave the patient with a longer lever arm. The foot doesn't look normal also. So instead, what you should do is make a very conscious effort to sublux the foot back in relationship to the tibia. Sure, the nail at that end makes it difficult for you to put the nail within the calcaneal body, within the calcaneal neck, but you can certainly do so. Now I'm going to show some videos here. Let's see, exit out of this. Okay, so observe carefully. This one side. Is it a normal gait? You might think, for a casual observer, it appears very normal. But this particular patient has a fusion on one side. And obviously the side which has got less muscular, the calf wasting is the one which has got a fusion. This particular patient had this osteoclastoma, and somebody put a cement blob, and she had managed with this for a couple of decades actually before she came to me, and we did get a hindfoot fusion. You can see how and posteriorly subluxed the foot was. So you can see the tibia is at almost on top of the talar head and neck aspect. So we moved the foot back. Okay, so that's important simply to know. I'm showing the picture of a hemostat or forceps, as in some countries it's called. It's because you have to make sure that when you are subluxing the foot back, especially, and you might be closer to the neurovascular bundles. And really, after you incise the skin, you should use this hemostat to go all the way, make a generous incision. There's no minimally invasive nail entry from the plantar aspect of the sole. You need to make a generous incision and use a blunt dissection all the way down to the plantar aspect of the calcaneus. Very important. Now, if you just look at the lateral view of this particular nail, you might think that, whoa, this looks great, So this nail, the distal end of the nail has got a great purchase in the calcaneus. But if you see an axial view, you like I said before, it is not entering the right, so it's entering into the medial, so it's wall of the calcaneus. So it's not actually getting a good purchase in the calcaneus itself. So, there is a problem with that. That's because, as you know, the calcaneus is much broader posteriorly, but as it comes anteriorly, it is narrower and almost deficient on the medial aspect. So we have to understand the three dimension of the calcaneus. If you have the opportunity to use different types of nails, and you might choose a nail with a lateral bend for this particular reason. Here is a straight nail. Sometimes if you do not shift or not pay attention to where the nail is entering, and if you have a straight nail, there is a possibility that you may violate the medial wall and sometimes ST fragment, there you can see. Yeah. And we did a cadaver study comparing the straight nail versus a curved nail. These curved nails have curved not only posteriorly, but also laterally, some of these. And found that a straight nail more often goes to the medial aspect and has less of a bony coverage in the calcaneus. So I want to introduce two important concepts which I kind of learned or stumbled upon doing this nailing over the years. One is a need for malleolar osteotomy, talking about both medial and lateral malleolars. Dr. Rajiv Vora has shown great cases where he used this lateral malleolar osteotomy, but not very often we talk about medial malleolar osteotomy. And need for additional stability. I know you have a nail with interlocking screws in the calcaneus and talus, but I think at times you need to augment with implants which do not come with a nail, but you have to see if additional stability is necessary. So I did mention about the posterior displacement. So if you do a medial malleolar osteotomy, you can certainly push the foot posteriorly much easier and reduce the lever arm. And it can also allow medial displacement of the hindfoot because, as you push the foot posteriorly, you should also make a conscious effort to push the foot medially slightly so that you can enter into the body into the meat of the calcaneus and not violate the medial aspect of the calcaneus. So here is a nail which you can see clearly a clapper in the bell effect because there's not much enough stability in here. I'm going to show a couple of case examples and expound upon this. So here is a patient where you can see the body is crushed, the talar body is crushed. You can see the height of the hind foot is reduced. And obviously you can see a varus deformity, a severe varus deformity. How do you reduce the anterior subluxation? You can certainly fuse this over here. You can accept this a longer lever arm and fuse this. But I implore that you should try to move sorry, beg your pardon. I don't know what happened there. I suggest that what you should do is move the tibia anterior to the foot. And to do that, you might resort to extensive deltoid release or soft tissue release so that we can push the foot back. But that's that becomes easier if you do a medial malleolar osteotomy. So I'm going to show some clinical scenarios of intraoperative pictures where you can see how that is done. So that's the medial aspect of the ankle. So we're using this osteotome. Sorry, I need to remove the pen. So that's the medial malleolar osteotomy. You need to, instead of releasing the soft tissues and disrupting the blood supply, I think this is a much better option. It allows you to release all the structure, and you do the same thing on the lateral side. You can see how much of a subluxation I can get of the foot. This is your tibia there, right there, and that's the foot. Let me get my pen back again. So you see, this is the foot over here in relationship to the tibia. You can actually move the foot back and forth easily. Now you have both sides osteotomized. And this is what it was before medial malleolar osteotomy. You can see how much of the foot is subluxed. Now I gained the height as well. If you notice that I gained the height because I'm now trying to get the vascular aspect of the talus unite with the vascular aspect of the tibia. So the other thing I want to talk about is, you see, when you put the tip of the wire here, okay, you should feel the bone there. Now, if you feel the bone and the tip of the wire appears up there, that means you are on the medial aspect of the calcaneus. I hope folks understand. So when you're introducing the wire and you feel bone right there, that's pretty good. Now, but if you're putting the wire and then the first time you feel bone is right here, that means it is on the medial aspect or the medial calcaneal wall. Very important. So you need to have a lateral fluoroscope, and the first time you touch the bone, it should be right at the most plantar aspect of the calcaneus. Like I said before, you need to get good tibiocalcaneal alignment view. And those are some of the intraoperative pictures. You drive the nail, you fix it, and you get good results. So, that's before and after pictures. You can see we corrected the varus deformity, and you can see the height has improved, and you can see how far we brought the talus just to articulate arthrodesis with the head portion of the talus. So the tibia is right now here. So I'll share another case, and then we can end my presentation here. So this is the patient which came after a plating for ankle arthrodesis. You can see the fibula is missing, and the patient has severe valgus deformity of the hind foot. And just by correction, you can see there's a big empty space. So we put a bone graft here, but we were able to correct the deformity and get the hind foot under the tibia. And you can see how far I had to sublux that, because like I said, I really wanted to use the vascularity of the talar, head and neck, and also reduce the lever arm. But it makes it very challenging to get to the anterior part of the talus, but you can do it. But at times you are left with very little bone in that region. So you see, there's hardly any bone there right now. So in those scenarios, I really, after you put the nail, use the interlocking nails possible. I use additional screws. So that's but because the purchase may not be enough. You see. So I use additional screws. As you can see over here, these are not coming with a nail. They are not interlocking nails, but whatever stability you can give, you can. This patient had gone on from that to that, and before and after pictures, you can see we corrected the hind foot alignment and so on and so forth. So in conclusion, I want to say that position of arthrodesis is important, just like Dr. Rajiv Vora has mentioned for his ankle arthrodesis, because you're giving them a permanent attitude of the hind foot, and you could mess that up. Another point which I highlighted was, instead of doing a deltoid or soft tissue release, you could certainly use an osteotomy to reduce the deformity. And like I said, if you consider the 3-dimension anatomy of the calcaneus, it is a little deficient as we go anterior. So be mindful of that purchase in the calcaneus. If you're not able to get good purchase in the calcaneus, don't hesitate to put in additional implants to produce, get more stability in that direction. I want to thank you again. Thank you, Dr. Shantanu and the panelists for this opportunity, and always love to share my thoughts with you folks.
Thank you so much, Panchavavi sir. I know it's around 7 a.m. in the morning, 7 a.m. there, and you are up and about at this hour. And your presentation was really excellent. We could hear some very finer points about how to feel the bone. The first thing, you feel the bone when you put the bone on the lateral view. So these were the finer points. We are really thankful to you. But hang on, sir. I hope you stay with us for the whole length of the webinar. There will be answers later. Thank you very much, sir. So from USA to Australia, from 7 a.m. to around 10:30 p.m. for Mark. So Mr. Mark Blackley has been my teacher, my mentor, the chairman of the Foot and Ankle section of Asia Pacific Orthopedic Association. I could just see how magical he is with his small incision surgeries. So that's why I take great pleasure, and it's an honor to have you here, sir, for your presentation on minimum invasive ankle arthrodesis. Over to Mr. Mark Blackney.
Well, I very much thank you, Dr. Kumar, for inviting me here. And I'm very privileged to be amongst some wonderful speakers and faculty. So I'm going to share my screen and start my talk. So please. Give me a minute.
No problem.
Now, can you see that okay?
No, we cannot see your screen as of yet.
Oh, can you see it now? Okay.
No.
Okay, we should be okay now.
Yes, we are. Thank you.
All right, thank you. All right, so I'm going to talk about mini open ankle arthrodesis today. And this is, funnily enough, very similar talk to Dr. Vora. And I think it's wonderful that, we can agree from Australia to India with this technique, because I think it's very useful and very reliable technique for ankle arthrodesis. So I won't go over some of the things that have been said before. It's safe to say that there have been many techniques used in ankle arthrodesis, and the position and anatomy is very critical. But the major problem really is getting the bone to unite, and that is something that stresses a lot of surgeons. The modern principles really involve around the anatomy and mechanics. Minimal bone resection is very good. Subchondral drilling, creating blood flow. Using bone graft when indicated. And for most people, the treatment is of compression screws. There's a number of approaches which have been described already. This is a case of arthroscopic ankle arthrodesis with 3 screws. This is a case using anterior plate and some screws. And similar to Dr. Vora with the transfibular approach, multiple screws. But if you see the picture on the right is of an ankle arthrodesis using 2 screws, and that seems to be the majority of surgeries performed for ankle arthrodesis. But when we go down to the forefoot, a smaller joint, the most common treatment for arthrodesis of the first metatarsophalangeal joint, certainly in Australia, is a plate and screws. So it seems odd that a much smaller joint would have a much stronger fixation than the ankle. And patients, as we know, aren't getting any smaller. And so to have two screws holding a joint with a very small surface area and massive lever arms would create a risk of fixation and the ability to hold the bone for long enough while the bone joins. And this is probably the major cause of non-union. So when we look at some meta-analysis data, this one was published a few years ago, but there were some very high rates of non-union and ankle arthrodesis generally. And 10% of non-union was the average, and that seemed very high. And these are some cases of non-union that I've had to see and treat over the years from other places. The reasons for failure really are around failure of preparation, failure of fixation, immobilization and compliance of the patient, and then other problems such as vascular problems and infection. When we look at preparation, that is a number of techniques are used, and that will depend on your local region and what your facilities have. These can vary from curettes and osteotomes to saws and to burrs. My current preference is to use a burr. I don't like to use saws because of the heat that's generated. So if I didn't have a burr, I would use a osteotome or curette. So Dr. Vora talked about arthroscopic arthrodesis, and this is a very useful technique with very good results, but it is usually used for patients without much deformity. So it's good in an in situ fusion, but it is technically challenging, and I still do quite a lot of arthroscopic arthrodesis, but mainly for the simpler cases. But if you have someone who's very large or if they're deformed, you certainly need a different approach. And so everyone who does ankle arthrodesis should have one or two approaches that they prefer. So I use arthroscopic and I use the mini open. And so I would say that some ankles are not suitable for arthroscopic arthrodesis, but also some surgeons are not suitable for arthroscopic arthrodesis because it is quite a technical procedure and you shouldn't really try it unless you feel suitable.
Tenderness, swelling beneath lateral, there are multiple causes, but the most common being missed flat foot diagnosis, where flat foot, because of the flat foot, there is
Rajiv,
valgus and lateral subfibular impingement.
Rajiv.
There seems a slightly large ostical posterior.
Rajiv, sir.
So there could be
Dr.
even
Shah.
a slight impingement by the posterior process of talus there. But I think we need a standing evaluation as well as perfect clinical evaluation of the best.
Rajiv, sir, you need to mute your. Yes, please go on, sir.
That's all right. Thank you. So really I'm going to talk about a mini open ankle arthrodesis, which strangely is very similar to Dr. Vora's technique, only is a slightly smaller incision, but you will see that it is a very good universal technique for a general orthopedic surgeon to develop to provide a very reliable and safe ankle arthrodesis technique. Provides excellent compression, fixation, and is very good for deformity correction, and is much safer, if you're a general orthopedic surgeon rather than a very well-trained or very high-end foot and ankle specialist. And this is the approach, and this is the result. So we have a small anterior incision, 2 compression screws, and an anterior plate. And I'll talk about the plate in a minute, but the principles are the same, whatever plate you use. Now, this is the same paper that was quoted before, and it's an excellent paper, and it really outlines the key part of the success of the anterior plate and cross screw technique, because it has much better stiffness and stability in all the planes, particularly in the sagittal plane, where you're going to find most of the problems if you're going to have any failures. And these are a couple of reports of papers describing similar techniques with far better fusion rates and than you would see normally. So very high fusion rates, which is not seen with screws. This is a case, one of our earlier cases was similar to what you've seen with Dr. Vora with this is a bent plate with that's a distal radial plate that we used and bent. And also the other one is the pelvic reconstruction plate, which can be bent. Another similar case where we corrected a varus deformity and were able to get nice fixation. However, this is a plate which we've developed here called the TTF plate, which we developed with a German company, Merit, and it's been used very, it's probably the most popular plate for ankle arthrodesis in Australia because it's specifically designed for the ankle. There are two angulations. Mostly it's the 99-degree plate, but it is specifically designed for the ankle. So I'll just go through a case so you can get a bit of an idea of how this is done. This is an ankle, varus, a bit deformed, and it's not a very big incision. It's about 5 to 6 centimeters in length, so it's not small. It's not arthroscopic, but neither is it a very large incision. But even through this small incision, you can see, you could get an excellent view of the ankle. And so you can see everything you need to see. You can remove osteophytes. You can distract the joint to get in easy to remove the cartilage. And you'll find that your ability to access all parts of the joint is very useful. As I said, once we expose the joint, you need to remove the cartilage. My preference is for a burr, which is lightly run over the bone so it doesn't cause too much heat necrosis. But you can use whatever tool you feel good, but preserve the contours of the joint as much as possible. This is, once you've prepared the joint, you're going to put in 2 cross screws. This first one is the guide wire from the medial malleolus, which goes into the talus slightly more anteriorly than the lateral screw. So I think this is a little video of it going in, and just on a model. So this is the first one. And then we have the second one, which goes in laterally, which is just anterior to the fibula. So, but it will go in and be slightly posterior to the medial malleolus screw guide wire. And once the wires are in place, you can put the screws in, or you could put the plate on first, but it's probably better to put these screws, get some compression first. So once we do that, you can see the positions of the 2 wires, with the lateral wire more posterior and the tibial wire, medial wire more anterior. And this is the plate. So after the screws have gone in, the plate is applied and fixed with K wires to check the position. So once we see that, we can see that it sits nicely and very nicely contoured on the ankle. Then we screw the talar half. And then once we've done that, we would then loosen off the tibia and obtain compression before we place the tibial screws in. So now we're putting the tibial screws in, and that will allow us to get compression and bring the plate down onto the bone. So we're now just putting the screws in, and you can see that it will conform very nicely with the ankle, and that will provide excellent stability across the joint. And this is once it's finished.
Just that's it.
Then you would fill any gaps with bone graft, either local graft, harvested graft, usually from the calcaneum. It really doesn't need to be a lot. And this is the sort of result you would achieve around 2 to 3 months following the arthrodesis. Another similar case. And very similar to Dr. Vora's case. So the principles are exactly the same. And I think it's a very good technique. You don't have to use this plate. You can use a pelvic reconstruction plate or a radial plate, depending on what you have available. Another case with some deformity correction, calcaneal osteotomy as well. So it's nice. It's a good way to treat a non-union if you actually get a non-union. This was a case which was had a non-union, and we put some bone graft in the front of the ankle and a plate across. So often when I'm teaching people about this technique, I tell them that their first case should be the treatment of one of their non-unions. And once they've done that, they generally want to transfer over to do this case. Post-operative care is very similar. Usually I tend to use a boot, but a cast is very valuable. And then it takes 10 to 12 weeks to fully heal. These are the options. The Australian results with some of the users are really around 95% fusion rates. So it's a very useful and reliable tool. Bone graft is very much up to the person doing the case, but I tend not to use any artificial or biological grafts for a straightforward ankle arthrodesis. So it's a safe approach. It's a very good universal approach, and you could add larger plates if the patient is heavier or if you have more bone to deal with. And it's very useful for treating non-unions and very good for deformity. There are some other advances in plates that we are using now in Australia, which include smaller plates again, including an arthroscopic assist plate as well. So yes, so I think overall, I think we have the same approach, Dr. Vora, and I think it's a very good approach for a general orthopedic surgeon. Thank you.
Thank you, Mark. Just reinforcing what I was saying.
Exactly.
Exactly. So now, Shantanu, there were two questions. Can I just go ahead with it?
Yes, I think you can.
There was one question after transfibular approach, what happens to the subtalar joint? And actually, if we look into the stability of the subtalar joint, it is more of dependent on the cervical ligament, the lateral talocalcaneal ligament, and the interosseous ligament. So we are just by removing the fibula, you are just taking the calcaneofibular ligament. So that is, so probably the subtalar joint doesn't get affected into. And the other question was whether you want to put in the plantar flexion or in the neutral flexion. Actually, if we do the gait cycle, and when we start our stance phase, our first thing which is actually going to hit the ground is the heel. So that is how the stance phase starts. Imagine if you have a plantar flex foot. So everything is right from the start, it's gone. So that is why it is important to get your neutral position. I think these were the two questions which I could see directed to me. If you have any other, I would be more than happy to answer.
There's one question to Panchbhavi, sir, which is from Girish Motwani. And Girish Motwani, a very fine and young for an ankle surgeon from India, he is asking, In undeformed ankle and subtalar arthritis, which is better choice in general, straight nail or 5-degree valgus nail? The question is to Vinod Panchbhavi, sir. Panchbhavi, sir, you need to unmute yourself.
You are.
Yeah.
People are, fibular osteotomy for ankle arthrodesis. People used to take the fibula away. Then we moved away from doing that because, sometimes in future they may be able to convert ankle arthrodesis into a total ankle replacement. I don't know, but there are some situations that won't be warranted. But I think with fibular osteotomy, it certainly gives you a nice approach. You can see the entire dome from the front to back. And you can also, like Dr. Rajiv Vora has mentioned, you can decorticate the medial aspect of the distal fibula and bring in more blood supply to the talar body from those occasions. But if you remove the fibula completely, yes, I don't like that. You see, you can do an osteotomy to get an approach, but fibulectomy, I do not agree with it, because I like to use that fibula in addition to the nail, in addition to whatever you do. I like to use the fibula. I retain the fibula. I'm not one of those, even in diabetic patients, I'm not throwing away the fibula. If I may cut it to get approach, I may cut it to push the foot back to get a better alignment, but I will not throw that away. I hope that answers Girish's question.
No, sir. The question was whether you would use a straight nail or 5-degree valgus nail.
Yes, that's the other question. Yes, sorry. I didn't have my breakfast yet, so I'm still a little low in my energy. So yes, the straight nail, I know. I mean, the advantage of straight nail is that you don't have to mess with the alignment to, overcorrect it and undercorrect it. So that's much technically less challenging with a straight nail. But, you can certainly use a straight nail. You have to pay attention to shifting the hind foot slightly medial to be able to get into the calcaneal substances. If you use the curved nail, if it is a lateral bend nail, technically slightly more challenging. You may not need to shift that much. So you see, if you have different types of feet, you have a cavus foot, you have a flat foot. Flat foot, it makes it much more difficult for a straighter nail. So you may choose a curved nail. But if you understand what the nail does and where it enters, you can modify your technique to use either one of those nails.
Right. So moving on, I guess the fourth lecture is from me with the permission of all my seniors. May I just present my very small talk on subtalar arthritis?
Please do.
Yes, sir. So I'll start my screen sharing. Right. So is my screen visible to all?
Yes.
All right. So there I go. So it's a small presentation on subtalar arthrodesis. We know in our country, we are not very unfamiliar with such cases of calcaneus malunion. There will be a lot of fall, mostly due to industrial accidents, and people are the victims are generally poor. They will go to some village bone setter or to a general surgeon, general orthopedic surgeon maybe, who might not be able to do it properly. So it's not very uncommon to come across cases like this and this, and there will be, of course, subtalar arthritis. So, as we all know, the most common cause in our country is post-traumatic, and history and a clinical examination for such cases are very important. I will not go into detail. The most prominent feature would be there will be pain on walking on uneven surface. These are the other things. Clinical examination, of course, is very important, where these are the points which need to note: the alignment of the foot and ankle, soft tissue condition, range of movement of all the adjacent joint, the knee, the hip, also the forefoot and metatarsal joints. We also have to see the neurovascular status of the limb, tender Achilles tightness, very important, because sometimes we may have to do some lengthening of the tender calcaneus or gastroc-resection. Imaging, very important, apart from the standard AP lateral We also have to do a standing lateral view of ankle and foot to actually judge the talar tilt in the lateral view. The other important views are Brodmann view and Salzmann view. These are the Salzmann view, Brodmann view, we all know that. And this is how we take a standing weight-bearing X-ray. In this is X-ray of a follow-up case of a guy who had a fall from height, also had a minimally displaced calcaneus fracture, where also we can see that he is developing subtalar arthritis. Management, of course, we have to start the management as soon as possible. Conservative management does have very small place, but mostly we have to resort to surgery. And the surgical management depends upon all these important factors like the type of arthritis, severity of disease, location of the arthritis, and sometime more than one surgery may be needed. And if it is subtalar arthrodesis we have to do, then we have to see whether there is deformity or not, whether there is loss of height due to malunion, or whether it is associated with any kind of deformity. So if there is no deformity, we have to go for in situ fusion. And there's a lot of height, we have to do some kind of distraction and put in bone graft. And if there is deformity, we need to correct the deformity. These are the different approaches already talked about by Rajiv Vora sir. And these are some general conditions, of course, in all arthrodesis. Dr. Vora sir already said that we have to get a broad cancellous bleeding surface, rigid fixation with compression. That is, compression is very important. And we have to get a subchondral bone which is bleeding. We have to bring it about by drilling. And again, these are general conditions. We have to plan our incision as per the pathology. Sometimes it is better to resort to a lateral extensile approach rather than many approaches if the beginner is taking on the job. There has to be adequate soft tissue mobilization, and we have to avoid nerves, we all know. And subtalar arthrodesis, the deformity correction answer like this. If there's loss of height, I said posterior grafting is required. The correct position, and by bringing about subtalar arthrodesis, the FHL does mark the limit on the medial side because we are operating from the lateral aspect. We have to look for FHL on the medial side. These are points, but what I really want to show is this video.
We could see a very large bony exostosis on the lateral aspect of the ankle. That was a displaced, malunited displaced fracture of calcaneus. So I shall proceed to excise it. I have the
so these are the exostosis will impinge on the tendons and cause pain.
There it is.
So cutting off, and this bone actually, as you will see in the video later, is a big piece of bone, and this can be used as a graft material. So we have to size properly whatever is required. It can be generous at times, and we don't have to shy away from that. That's a big chunk of bone I'm taking out.
So large chunk. That's right.
Yes, large chunk of
And now
bone.
we can see the subtalar joint here. So basically this video was to show how a big lateral exostosis can really be symptomatic.
Right. And this is the second part of surgery where I'll show.
So now the bed has been created, the bony beds have been created for arthrodesis. We can see that this is the inferior surface of the talus, which has been made clear of its articular cartilage, and the drill holes have been drilled just as to make the bone grow into each other. And this is the calcaneal posterior articular facet, also cleaned up for the purpose of arthrodesis. And this is a bone graft from iliac crest. So we need to put a bone graft so as to achieve the correct length and height of the arthrodesis. And we are putting, the major chunk has been put. And after that, a lot of, can you focus it here? A lot of bony chunks are there which will be put, and then the 2 screws will be put. Thank you so much.
And this is how it is done.
Now we can see that the subtalar joint from a distance, please.
Nicely
The
packed.
subtalar joint, the arthrodesis side, has been packed with cancellous bone graft. Thank you.
So if done and closed properly, you'll have a very nice kind of healing and nice post-op results. Yes. So subtalar arthritis, few points here that have to be combined: osteotomy for deformity correction, as I said earlier, and implant placement has to be done from an odd-bearing area of the heel. Screw head are to be countersunk so that they do not cause any kind of pain, and sometimes. And this picture has been borrowed by Dr. Rajiv Shah sir's presentation. You need to use one extra screw for increased stability. Complications, if not done properly, this is what you get. It is very important that you get the direction of your screw right. Lag screw, whether to use a lag screw or a fully threaded screw. When you just are doing in situ fusion, probably lag screw are good enough. But at times, when you have to gain height and you're putting at a big bone block, the good idea is to hold it there, not to have too much of compression. So instead of a lag screw, it is important that one uses a fully threaded screw. So take home, good planning is key to success. Key as a meticulous detail. Try to make the learning curve as small as possible. Thank you so much. So with this, I think we have come to the most important and interesting part of the webinar, where it is over to Dr. Rajiv Shah sir. He'll be showing many interesting cases, and I'll request all my panelists to take part into discussion with a lot of enthusiasm. Thank you, sir. Dr. Rajiv Shah sir.
Good morning, Professor Panjbavi sir, and good evening, Dr. Mark. Both of you have made a huge difference in my life, and I'm always going to be grateful to you. And good evening to our beloved President of Indian Foot and Ankle Society, Dr. Vora.
Good evening,
And
sir.
good evening to Kumar Shantanu, who is the future of Indian Foot and Ankle Society. And thank you, Kumar, for bringing me here. I am the last in the lot. Hope I try to keep you involved. I hope I am audible as well as you are able to see my screen.
Both very clear, sir. No problem at all.
Okay. So this is my disclosure after lockdown, that I have burnt out with all my ego to be called as a surgeon. And with this humble attitude, I try to present my cases. And this also, I am going to make sure that you don't go this way, nor I'm going to make sure that you have this kind of an advantage. So, going ahead with my first case, 2 years post subtalar joint fusion, patient comes to me with persistent pain. Pain is on the outer border of the foot. Patient is not able to walk. If at all patient is able to stand or walk, is with some orthosis. Kumar, with this small information, could you guess something?
Yes, sir. Maybe another views of X-ray.
Yeah. But with no further view, with the complaints of patient that patient has got pain on an outer aspect of the foot, unable to walk, unable to balance himself. Can you guess something?
Yes, sir. Because the screw hasn't put in such a way, it has caused problem with certain soft tissues.
Yeah. So the most important view you would want would be a hindfoot alignment view, where the fusion is done into varus, and that's what I had to go in and correct the excess with a revision fusion. And in fact, I also increased the height of the heel. The another case of ankle fusion.
Excuse me, sir. Can I add something, sir?
Please, please, please.
So on the lateral, if you go ahead with the lateral view, you can actually make it out it is in varus. If you see
Exactly.
where is the fifth metatarsal, it is lying right down there near the floor. So it shows that there's a lateral pressure over there and this hindfoot is. So even with the lateral view, we can make it. That's what I know everyone understands in the panelists. I just wanted to convey to the general audience that even in
Yeah.
the lateral view, you can convey this.
And you can even look at this high arch.
Yeah. It's
Yeah.
into cavus and the varus, you can realize even on this.
Yeah. So fixation with one screw and into varus, and that was the root cause which was corrected. This was another patient who came with the pain and instability to walk. Kumar, any guess why is that? He must be having a lot of pain, though the ankle has fused nicely. Inability to walk.
Sir, it is a cavo equinus kind of deformity that I can see.
Yes.
There's tightening of the tendocalcaneus, and all this must be giving him a lot of pain.
Yeah. So in sagittal plane, ankle is fused into equinus, and that is what was corrected with an supramalleolar osteotomy. So the message is fusion position plays the most vital role. So that is the message I want to give through this case examples. Going forward onto case number 2, this was a female,
Right,
52 years, who had a ST fusion for calcaneus malunion. Dr. Bora, would you wish to comment on this ST fusion?
Sure, sir. One is I think there's an inadequate preparation of the joints. I still see there's not adequate compression, and even the instrument used for compression is a fully threaded catheter screw. When you are doing an in situ fusion, you have to have a short thread compression screw, partially threaded, which are 16 mm normally, which I use for this. So the reason here is inadequate preparation, as well as apart from that, I don't know if it's a lateral or not, whether there's some coronal sort of malalignment there. I can't make it out. This appears reasonably okay, but it is because of those the screws which are used, and that is.
So it's now 9 months. Patient is having pain and inability to walk.
And there is a fibular impingement also, if we see here in that view.
So this is the X-ray at presentation, and that's the clinical picture. This was done with a sinus tarsi approach. Dr. Vora, obviously this needs revision. How would you revise it?
So I would use the same incision. And if we look, the talus is slightly, the angle is, does the patient have any anterior impingement?
Patient do not have anterior pain.
So definitely, I would revise through the same incision. And I would like number 1 to use a good bone graft on this, good preparation of it, slight distraction, not much. If the patient is not, when you're putting into it, then the screws should be, there should be adequate compression. And then I would, if you see into the medial facet, anterior and the medial facet, they also need fusion into this. So
one of the screw appears to be broken.
Yeah, it's already broken.
Yeah,
it's going to be challenging to remove that tail end of that screw.
So, Professor Panchpavi, would you not be worried about the same screw track bothering you when you go for the fusion, revision fusion?
Yeah, that's what I was thinking. You know, so that doesn't look like a cannulated screw. Or was it? I can't make out if it was a cannulated screw. Then I suppose you could reverse.
Doesn't appear to be cannulated screw. Doesn't appear to be a cannulated screw.
Yeah, these are cancellous screws.
Cancellous. So it's not a cannulated screw. You know, with good mobilization, you could be lucky depending on whether it is too lateral or too medial. If it is too lateral, I think we could still take that tail end out. And
central. Both the screws are central.
Both the screws are central. Yeah, that's really challenging. But you know, you could get lucky sometimes to get the tail end of that screw. out. But yeah, I mean, you know, the principles have been very well expounded by all great speakers here. You know, this preparation of the joint, even if you go second time, it's really good exposure, real good preparation, both by not only drilling those surfaces, but by feathering them. You should make those surfaces kind of as if a bomb went off there, you know, so you need to create so much inter digitation of those cancellous region and putting bone graft. So obviously I'm going to remove those screws, and if I'm using the same track, then I have to use a larger size screw. But I think, you know, getting the bony opposition, preparing the arthrodesis site would get us some success here.
Okay, so I like to take Broaden's view for always for better visualization of this subtalar fusion, and I monitor my subtalar fusion through the Broaden views. And so 10, 20, 30, and 40. And so I went in for the revision surgery. I used extensile lateral approach because I wanted to be more cautious. I removed both the screws. They were not the cannulated ones. And then I pushed in two 7 mm screws and 2 anterior screws. And also I used a compression plate plus bone grafting. So I never wanted to, you know, leave any corner, any stone unturned, and this is what I did. So the message is that compression is always required. Partially threaded screws are best for that, and you need to do sound joint preparation. But then this patient, Mark, after sound union over 3 months, had a lot of pain. Any guess? This being the last pictures.
Well, I was wondering whether they still have, is the pain, whereabouts is the pain?
Pain is onto the anterolateral aspect of ankle.
Well, one would suspect that there may be some persisting calcaneofibular impingement.
Okay. Kumar, any
Sir.
guess?
So I guess the pain is due to impingement only, or maybe it is the screw from lateral to medial is impinging on some soft tissue structure.
Oh, but he has got pain on anterolateral aspect. Dr. Vora?
So I don't know, once this is fused, if the patient has developed some instability in the ankle joint, because the stresses are now on the ankle, if he has an associated injury to that, we can have. Otherwise, in this case, I don't find much reason. Of course, the soft tissue irritation, maybe to the peroneal tendon or sural nerve neuritis in these cases, which can cause a lateral pain. But
now I'm opening the secret. My lateral screw was into the anterolateral gutter of the ankle.
Wow.
And so unfortunately I do not have the later x-rays, but this screw was impinging into the anterolateral aspect of the gutter because I did not monitor my fusion with the AP view of the ankle. So that's the message I want to give, that monitor passage of your screws for ST fusion in your axial, lateral, as well as anteroposterior view of the ankle, because sometimes you feel that your screws are going nicely, but you may be out laterally. And Kumar showed one case in which the screws were into the lateral gutter. So my one screw was into the lateral gutter and I had to remove it before even fusion was so solid. So that's where you can make the mistake. Okay, going to my case 3. We say, and I think you also, Dr. Vora also said, that there is an issue of gait after the ankle fusion, and gait never returns to the normal after the ankle fusion. And Dr. Vora, I'm going to show you a video of my patient it is now 2 years post ankle fusion. And if you could come up and say that which was the ankle which was fused. So here it is. So it's now 2 years since we fused the ankle in this young man of 28 years. Can you guess?
Number one, I never said that the gate is so.
Okay.
so,
But number two,
so I don't. It is for me. It's really difficult to make it out.
okay. Okay. And I run the next video. Okay. Now coming to this patient's history. A 29 years old male had a compound grade 3 fracture of this nature, which was treated with debridement external fixation, plastic reconstruction, and this is how it was finally fixed. And this is how the plastic reconstruction looked like. There was a flap on a medial side. And then this got infected. And then it was after the third surgery, he lands up with me. So I did the surgery number 4, went in, debrided, put in the cement granules, antibiotic impregnated absorbable cement granules, external fixation and plastic coverage was also given later on. And this is how the situation looked like. 6 weeks, infection under control. Mark, this is after the 4th surgery that you have a plate inside, you have a gap, you have a defect, and wounds are clean. Would you be thinking to go in and do something minimally invasive, or you would go in for the open surgery? Which approach, which implant?
Well, it's quite a complex case, so you want to be very careful, and I perhaps wouldn't want to go in so quickly as only 6 weeks. But let's assume that it's all clean and you want to go in.
Yes.
So does he have? It looks like he has some bone loss now. Is that correct? So he needs to have corticocancellous graft inserted. So in that situation, you could still. It would depend on the previous flap surgery and where you could make it a safe approach. So he's clearly got a lateral incision, and I see that the medial incision was the infected one.
Yes.
So you don't want to do that. So you would probably have to go in through the lateral scar, remove the plate, take the fibula back, put some graft in, and then look at fixation, which would probably be just screws if you're going through the lateral approach. Because you can't really put a plate in, unless you could put a plate, but you'd probably have to go down onto the calcaneum. So just off a 5-second opinion, that's what I would do.
Yeah, Professor Panchbhavi, how would you go about this case? You would also go laterally?
Well, I was thinking of a totally different approach, really. In these scenarios, I do take a MRA. You want to know where the vessels are going to these talus and the distal aspect of the tibia. Having had a past infection in there, those kind of sinuses, any implant, I'll be scared to put in, even though if you have CBC, ESR, C-reactive protein being normal, there's always a chance that you could get any implant infected there. If I want to play the safest and the patient is agreeable to this, I would do a bone transport in Elizarov. And I've had similar scenarios wherein they were pretty successful. I think that would be my approach. I think I see Shantanu raising his hand.
Yeah.
Kumar.
Yes, Kumar.
Yes, sir. It is very important for me to assess whether the fibula has united or not.
So fibula is not united.
Yes, exactly. That is what I was to say. So maybe we have to do something for the fibula as well. I'll remove the plate and do some fibular shortening. I don't think there is much of a loss. It is maybe less than 1 inch, maybe 1 or 1.5 centimeter only. I'm talking about tibia. So once I remove the fibular plate and cut a little bit of fibula, especially the proximal fragment, the tapering part of the fibula, and then oppose the two fibular ends, probably by doing this, I'll also be able to bring the tibia a little down, and then I'll be able to fuse it with talus.
Oh.
So what I'll do, I'll remove the fibular plate and then cut a little bit of fibula so that the fracture ends meet properly of the fibula. Then I put a plate there, then bring about fusion of tibia with talus.
Oh.
That's what I'm thinking.
Yeah, so that's a great idea. So you are also ready to give shortening. So I went in with the lateral approach. I removed the plate. I mobilized the fibula. I never wanted to give shortening to this patient. So I put in the fibular grafts and the cancellous grafts. Fibular grafts not to allow shortening, and then I used a screw and a lateral plate. I never wanted to go beyond subtalar joint. And he went on to heal, and he could walk normally at the end of 2 years. We have seen the video. So a message is that skin condition will dictate the implant positioning, and you could use a lateral, anterior or posterior plate depending upon the skin condition. And young patients, they really do very well after ankle fusion, those who may not be the candidate for total ankle replacement. And Panchbhavi sir, I'm going to show you one case of
Sir,
Elizaro transport. Yeah, please.
So before that, there is a question from audience.
Yes.
That question has also came to your mind. In the previous case, you have shown that you have removed the broken part of the screw from talus. So the
Yes.
question is, somebody wants to know how were you able to remove that broken screw?
Yeah. So what I did, I bent a K-wire and mounted it on a T-handle, and then I passed that K-wire distal to the screw tip, and then I passed in 1 or 2 other K-wires. So I just locked them, and then I pull all of them, and I could bring the screw head out. And I also had a disc punch of 1 mm ready to pick that screw
Out.
out.
Right.
Okay.
Thank you, sir.
So this is probably going to be another simple ankle fusion case, but some different variety, where a male 21 open grade 3 pilon variety of ankle fracture got infected, operated thrice, and then after third surgery, he was referred from Delhi to us, where he had ankle arthritis with a non-union proximally. So ankle fusion was thought about, but then what to do about this ununited fracture? Dr. Vora, any views onto this? Is a young patient, you don't want to give shortening, you also want that the ankle fusion happens at the same time, you don't want to give shortening. What would you do for such case? Sorry, it's only AP view.
In most of these cases, even if you attempt to do the fusion, you don't find a healthy bone to fuse, and you have to excise most of the. Most of the time it's an avascular sort of bone which is there. So to me, the best answer is the bone transport in this patient. If you somehow if you open, then if you have a very very good bone, you may think of reconstructing it, but most of the time I don't want to give shortening for all that. Elizaro is the bone transport, and Elizaro is the best.
Mark?
Yes, I agree with Dr. Vora that Ilizarov is the best choice in this complex case. More sort of implants and open surgery with the presence of so much infection, you're going to, it's a very high risk.
Yeah. So I was little heroic. The infection was under control. So there was non-union arthritis, and the patient was not keen on shortening. In fact, I never explained him about the Ilizaro because I knew that he was so much fed up of multiple surgeries, he may not accept Ilizaro. And so this is what I did. I extended my fusion mass proximally to bridge the ununited fracture, and I got the union, and this is how he healed, has gone back to the uh, function. So the small message I wanted to give is that choice of implant would depend upon the geometry of the fracture. And sometimes if you see on a left side, a bad pilon fracture with a bad skin condition can be treated with an antegrade nail for a fusion like this, or a fusion mask might require to be extended. Any comments, Professor Panchbhavi, sir?
That was very nice, actually. Impressive how you got the fusion. But I think the stability you provided allowed, even if there are avascular segments within the distal tibial metaphysis, you provided bone graft, and then I think a lot of stability or adequate stability to get this to unite. I think that was the recipe for success there.
Yeah.
And obviously a skilled surgeon like you, very important.
I am your student, sir. So this is going to be the case number 5. Professor Panchbhavi, male 28, road traffic accident, had polytrauma and bilateral lower limb injury. And this is what was on the left side, a simple comminuted segmental pilon fracture, intra-articular one, with the comminuted fracture talus, with the comminuted fracture calcaneus, with a small puncture wound. That was on the left side, and this was on the right side, a comminuted closed pilon fracture with fracture neck and body talus with comminuted fracture calcaneus. And this was not the compound one. Patient was reasonably stable on second day to go in and do something. Sir, your viewpoint.
Wow, it's very challenging. Obviously, you see the soft tissue is the king, and with that much trauma, the soft tissue disruption is going to be extensive. Obviously, I don't want to do any heroic operations, open up any flaps. These for me would be should be managed initially by gentle manipulation to get some kind of anatomy in the hindfoot, a proper alignment as much as possible in an external fixator frame. And I will allow the soft tissues to resolve first and then take it from there. I would do the same thing on both sides. So these are extremely challenging cases. And, did you say it was open, right? Obviously,
No, it was a small puncture wound on a left side.
But even then, you see, that means, the bones have exploded within the soft tissue envelope so much and displaced so much that they cause disruption. I certainly wouldn't be brave enough to do anything open to put implants or bring those pieces together acutely. Certainly, I would manipulate those pieces into best possible position to get an overall better alignment in traction and stabilize it with a frame so as to allow the soft tissues to recover from this severe injury.
But look at this right-sided picture. My issue is where to put in a calcaneal pin with this kind of shattered calcaneus fracture. Where to put a pin and get the traction.
Yeah, I mean, that's going to be a challenge. I think you can certainly use smooth wires and get some part of the bone to hold, to get some purchase. I think, I think you certainly can get some part of the bone, luckily, especially on the left side, you can see.
Yeah, left side, yes, but the right side was the issue.
Hard to see on the right side, yes. I agree with you, but I hope you could put some kind of traction down, maybe on top of the bone. You have to be innovative in those things. I think on table, those are the decisions taken on table.
Yeah. So
Can I say something?
yes, please.
Yeah, thank you, sir. So I think, as rightly pointed out by Panchbhavi sir, we have to first and foremost think of soft tissue, and then we cannot put any kind of a definitive implant as such. We have to take help of a lot of K wires here, maybe, and certain screws. So if I were to manage the right side, I'll assess the soft tissue, put him on some kind of external fixator. Then I can see fracture tailors. For fracture tailors, maybe I'll just use a screw or mini plates, and I'll use K wires to manipulate the fragments of calcaneus and try to bring about as much correction of height, length, and width as possible. And then first and foremost, priority for me would be to let the soft tissue heal, and then we can see and not allow the infection to set in. So if I am able to get an infection free good soft tissue healing, then on I'll see what I can do with the bones. So once I get that, maybe a lot of arthrodesis, few arthrodesis may be required here. So
Okay, so you're going to put a triangular frame, Kumar?
Probably a biplanar planes, a biplanar fixator, biplanar.
Okay.
So
So that is what I did.
Hybrid can be done. So foot frame and then you have a
Okay.
hybrid you can be.
So what I did on
Yeah,
left side, I put in a quadrangle external fixator on the left side, and on the right side, same quadrangle external fixator. So I could put in the pins with some manipulation of the fragment with a K wire over a 3 mm K wire over a T handle, and I could put in a pin. And this is how it was done. So Kumar, you wanted, now what next? After this X-Pix, soft tissues have settled. It's now about 2-3 weeks. Everything has settled down. Skin condition is conducive for you to go in. What would you do, Kumar?
So are you asking for the left side, sir? This one?
Both sides, both sides.
Okay, so this picture is in front of me, so I'll think about it, sir. So
Yeah,
if
please.
so, we are 3 weeks down the line from the index injury, and the soft tissue is healing well. So at this juncture, there's a gap in fibula. Fibular gap is there. We need to fill in this gap with some kind of graft. So maybe I'll take a little bit of fibula from the mid shaft of fibula and bring it there and put it there, and then put some kind of arthrodesis plate, actually spanning
Okay.
it quite higher up.
Okay. So plate would be on which side?
Plate would be anteriorly.
Okay. And what about this?
Anteriorly.
Yeah. What about the right side?
Could you let me have the picture, sir?
This is right side.
Right. Yes, yes, yes. So I can see here that talus is in a very bad condition here. The talar dome, I cannot see the talar dome in AP view in the middle picture. So the idea would be to again put some kind of graft there.
Okay.
Yeah, maybe.
Okay.
Yeah.
Dr. Vora,
Yes,
how
sir.
would you go about the right side and left side? So let's talk about left side first.
I have Dr. Rajiv Shah with me, so I'll send this patient to him. So anyway, this is joking, sir. To me, this is a case which I would ask my Liz Rogosh to do it. I don't want to do anything Herculean on this. Maybe after that, the transportation, and if we need to excise some part of the bone, we can do it. And later on, while transporting, if we need some grafting
There's,
we can do it. So to
Uh,
me,
Professor Panchbhavi?
In my hands, I looked at the
there's
difficult.
a sorry to interrupt. There's a question from Dr. Hitin Mathur.
Okay.
CT for planning.
Okay. CT for planning. Okay. I'll give you CT. So not a good CT scan, but it all shows bag of bones for the right side, and this is for the left side.
Not much help. That's true. Yeah, obviously these are very challenging cases. You won't have any a plan in the literature to say what to do next. But when you talked about the choice of external fixator, with these fixator works very well. But in my hands, I tend to use smooth wires a lot. I like to use a circular frame, which provides stability in all different planes. And I can leave that circular fixator for a long time. And the pin site infection, perhaps compared to the half pins, is better tolerated and less. And if for some reason patient is fed up of the frame and wants to get converted into or go for an implant, then obviously you need to again stick to the principles, getting the hind foot shape, the alignment right, and then fill in the gaps with plenty of bone graft. This particular patient will require a lot of bone graft, removing any articular surfaces. And then stabilization would be a challenge here. We can certainly put a nail, intramedullary nail, which goes way beyond that zone of injury, but getting some kind of a stability in the distal aspect in the hind foot would be challenging. You may have to use extra screws in addition to the nail. Plating, I shy away from the plating because I think, again, you will have challenges to find good bone to put screws. And I think biomechanically, intramedullary nail will at least hold the position of the hind foot better. So those are the options I will discuss with my patient.
Mark, your idea about this case?
Oh, this case is very, very difficult to know. I think you would find many opinions, but really I think you have to go with, in our facilities, you would be going with a ring fixator and taking each part individually. And I think you'd have to really be very careful with soft tissue infection, stripping periosteum to make the x-ray look good, but maybe not, give you a good union. So I think you'd have to have in our hands, a fairly minimal approach to try to achieve something in this patient. But what that something is may not be perfectly normal, of course.
Yeah, thank you. So, bilateral Elizaro would be a big challenge to this patient. And I wanted to give something different to this patient. So on the left side, I kept in the X-Pix and I passed the nail. And X-Pix was put in such a manner that the path of the nail did not obstructed by the X-Pix. And this was the union on the left side. After removal of X-Pix, no bone grafting was done. And this is the right side where I pushed in the nail, and this was the union at the end of 6 months. So right side 6 months, left side 6 months. TTC fusion.
Well done. Well done, Rajiv. This is a very difficult case.
It's a big learning there, sir. It's a really excellent one.
So then the question arises that when you do bilateral TTC fusion, how do this patient walk with this bilateral TTC fusion? And this is the gait of this patient at the end of another 3 months since he started walking. So in fact, he is doing up down. He's going by the train from Baroda to 80 kilometers and coming back every day. So bilateral TTC fusion cases also do well. That is what is the message I wanted to give with this case. Any comments?
Very nicely done, Rod. Very nice.
Thank you so much, sir. So this is a case where I followed the footsteps of Professor Panjbavi. A dentist, 24 years old, had 2 days after trauma, he reported to the orthopedic surgeon with a compound wound. And then orthopedic surgeon at the end of 3rd day did the debridement and he put in the talus back, put in the X-Pix and pushed in 2-3 K wires. Wounds did not heal. Infection was there. So surgeon debrided it once. It failed. He debrided it twice. It failed. He removed the K wires, kept only X-Pix. Patient was toxic, and it was at this time that I was involved into the management of this patient. So the question is that this is the kind of wound, and at this juncture, after 3 surgeries, this patient presents to you. So, Kumar, what would you do?
Sir, I think I'll have to take care of the infection. I'll do a thorough exploration and try to see and try to debride, take out all the dead and necrotic tissue. I'm not very sure about that fragment of bone which is already there. What is the amount of fixation? What is the what is the quality of fixation, and how much of dirt and grime is there actually? So I like to do it thorough debridement and take out all the dead and necrotic tissue.
Yeah, so very well said that you don't rely on anybody else's debridement. You always like to go in and have look on yourself. So this is what I did. I went in, I removed the dead bone, the whole lower third of the tibia came out, the whole of the talus came out, and then there was a defect of 12 centimeter. And then the question was how to bridge the defect. Obviously, as per Professor Panchbavi's suggestion, we went in with the Elizaro apparatus fixation, did the proximal corticotomy, started the lengthening, and then when we reached at the level of calcaneus, we docked it, we pushed in bone grafts, and then ultimately this united. Yes, patient had to undergo lot many plastic surgical reconstructive procedures, as you can see from these pictures. Professor Panchbavi sir.
Amazing. It's a great limb salvage. Obviously,
any further management? Would you protect this?
Oh, yes. Docking site, you see, I mean, you cannot rely on that. It requires protection for a long time. I've seen this breakaway again and again. You think patients are fed up because they have been in this frame for a year, 6 months, 9 months. They're always after you to remove the frame. But, you have to really make sure that the docking site has got bony fusion there before you can remove the frame and let the patient go. So, even after removing the frame, I protect them even further in a cast and in a boot for a long time.
How long do you protect for a boot? Say this patient took about 4 to 5 months to dock.
Yes. Oh yeah, a long time. I mean, I want to get a CT proof that it has got united before I go ahead.
Okay.
Let it be free.
Even after union, you see the fractures in these cases.
Yeah.
Even after union, you have see refractures in these cases.
So,
Uh,
Dr. Vora, how long do you protect these patients?
maybe
12 months,
maybe
right?
1 to 2 years, I would say. And apart from that, what you showed, the patient toxic and everything, personally speaking, I would like, if the other foot is right, I would like a BK amputation in this patient, because this limb, we have done quite a lot of salvage, and most of the time the people, they have pain, they keep on coming with the repeated infections, sinuses, then they do get even the refractures. So if I always try to convince the patients in such cases, and they can have an absolutely fantastic life with a good BK prosthesis than giving this limb. This is what I personally feel. I may be
So,
wrong in it.
yeah. So, Professor Panchbhav, you immobilize, I mean, you give a support or a cast immobilize for 2 years or for a year?
No, by that time the patient will be fed up and will be begging for amputation, I think. But I think at our place we sometimes use a crow walker or molded.
No, it's not a plus. There's anything. What you're saying, a crow walker or
Yeah.
what you.
So this 24 years old dentist was given craw for 15 months.
Yeah.
And then he was back in action. He came back 4 months with complaints of painless instability and fall. So this was the X-ray picture, and this is how he walked. So
I suppose he doesn't want amputation at this stage. He fought
no,
so
he
many
didn't want
years.
amputation.
No,
No.
after suffering that much, he won't want it. Otherwise,
Yeah.
on the first go, yes.
His
Bone
hand-
stock, the bone stock looks very good at that non-union site.
Yeah.
Certainly, we can give him another chance of
Okay.
with a hindfoot nail or a plate, some kind of stability with bone graft, and the soft tissues also look great at this stage.
So, Mark, what would you do at this juncture? Mark, this is
Definitely amputation for me.
okay.
I've done probably only 3 in my career amputation, but each time I'm glad I did it, and the patient very grateful and have a very good quality of life. So I for this patient, that would be my choice, but obviously you're not going to do it, Rajiv. So I'll be very interested to see what you do.
And some patients refuse, no matter what.
Yes, exactly.
They will not want an amputation. You can tell them, you can show them, you can get them to meet those amputees who have, gone through this and are enjoying. But even then, they will refuse to have an amputation.
He's a 24 years old boy and he is yet to marry. And
Yeah,
family is also very keen on not having amputation. And at this juncture, if you offer him Elizaro, he is already fed up of Elizaro.
No, yeah.
And he'll say he'll jump from the 4th floor, then going ahead with Elizaro. So what I did, I went in with the lateral approach. I did the freshening of the non-union site, packed with a lot of bone grafts and fixed it with the plate. And ultimately, united, he has gone back and has married. So
How many kids?
Well done.
So the most important message I wanted to give is that Elizarov lengthening case may fail even after 15 months of bracing. So you should always be watchful.
So the docking sites sometimes require a good preparation before you let them off the frame, you see. So, I make sure that at the docking site, when the docking site is reached, I remove all the fibrous tissue from the docking site and then provide them with some more time in that frame. I think that's very critical to avoid non-union at the docking site.
So that is what was done in this case, that when the
Even then,
docking, so
sometimes
it reached at docking, we went in, we removed the fibrous tissues, we put in the bone grafts, we compressed it, and
even then, yes,
even
and
then, yeah. Only thing I did not do, which you suggested, to get a CT scan before allowing him to do every activity. I did not do that, but I protected him with customized brace, PTB, patellar tendon weight bearing brace, for about 15 months. But still, it went on to this. So here is a female of 39 years old, but a progressive deformity since childhood. Since she had some childhood procedure, if you can see the scar on the outer aspect of the left leg, and this was the kind of standing picture this lady had, and she wanted a correction because her whole medial malleolus was touching the ground, and she was always worried that this might come out of the skin and she could have problems, and she also had a lot of pain around the ankle. So Professor Panchbavi, this is that 13-year-old female
yes.
begging for some kind of treatment. What?
Yeah, I mean, you can clearly see the foot is lying lateral to the distal tibia, and both all the bones, because this is a childhood procedure, throughout her growth they have become dysplastic because of the forces. Again, sticking to the principles, you have to bring the hind foot under the tibia, and it's not going to be easy. If you want to gain length or retain length, you can distract it, but acute distraction, acute reduction, it might compromise the vascularity. So depending on the length discrepancy, so if there's a lot to be achieved and you cannot acutely gain the length, so obviously I'm talking about putting the talus back under the tibia. It may not happen in one go. So you might need a staged procedure. So first stage would be, I can't see her kneecaps, but I suspect that the length of that left on the left side is
just going to show the video the way she walks.
yes. So if I wanted to acutely restore the length, I may be able to, depending on the soft tissue laxity, but I could compromise vascularity. So I'm thinking I may need to put a frame first to distract the foot, and then bring it underneath, shift it medially and bring it underneath the tibia. And then you could definitely fix it with either a nail or a plate at that stage. But getting the length is critical. Shifting the foot down and then medially, you could be lucky in getting it in one stage, but I think more often than not, it requires a gradual correction so as to not to compromise the vascularity. So in scenarios like this, I have actually done both ways. I've done initially a gradual distraction of the foot, and then using a Taylor spatial kind of a hexapod frame, and then shifted it medially. Once I got the alignment, you can shift it not only distally, medially, but also posteriorly, because you need to sublux the foot posterior to some extent, I think. Then you can, once you get the alignment, then you can fuse the hind foot in whatever position, with whatever implants you like to. So that would be, soft tissue release is going to be key. And whether it will take acute correction or not depends on the vascularity.
So vascularity is good. Mark, your thoughts onto this?
I definitely agree with Dr. Panchbabi in that I think a slow correction because she does look short, so you have to try to keep length. And then once you do have some reduction, you might even make, say, an early osteotomy of whatever the medial malleolus is there to allow some easier shift. but and a nail once the correction is obtained.
Dr. Vora? Dr. Vora? Okay, probably. Is he?
We need to
unmute
No,
that.
I'm there, sir. I'm
Yeah,
there.
please,
So
please.
to me, it is a two-stage procedure. Number one, when we are going to shift the talus under the tibia, what happens to the foot? You see, the foot is now compensating by this. Then probably even need another surgery after you have corrected it. The forefoot will really get supinated once you get. So I have to tell the patient that may need another surgery for that. Then coming to this, as Dr. Panchbabi said, but I have to open it. It is not like that you put the frame and stretch it. If you see there is a medial block there, that won't allow that won't allow anything to happen. So you have to remove that block. Once that block is gone, then you distract it, bring it in position and fix it the nail. Once you achieve the union in the hind foot, then depending upon the what the position of the forefoot or is there, you may have to do another surgery.
Kumar?
Yes, sir, I agree with the thought that on principle, we have to bring the foot directly underneath the tibia. It's a tibia kind of medial valgus thing, which is more medially. So the correction has to be gradual and some kind of device. I very honestly can say I have very little experience with such cases, but on principle, I can see that we need to bring the foot back into proper alignment. So honestly,
Okay. So my thought process was that if I bring this foot down under the tibia, I'm going to get the length. I'm not going to shorten it. And obviously, my thought process was also that whether am I over and above arthrodesis at the ankle, am I also going to require a supracondylar, supramalleolar osteotomy or not? So I decided to go ahead with a single stage correction of this deformity. And this was done just 4 days back. So these were the questions in my mind, whether I'm going to do supramalleolar osteotomy plus arthrodesis or a plus or minus calcaneal osteotomy or a ring fixator or intramedullary nail. But if I push in the nail, I'm not because of this high pitch of the calcaneus, my entry point would not be falling into the right place. So I had kept everything ready. And what I did the osteotomy of the tibia at the level of joint. So though the center of rotation and angulation was above the joint, I decided to correct this deformity at the level of the joint, removed the wedge and corrected this deformity and fixed it with the plate and screws and packed this whole area with the bone grafts, and the foot came right down under the tibia without much shortening. And this is how it looked like. I also added, and this is the distal medial tibial plate through which my screws I passed into the talus. And there was a stiff ST joint, so I was not afraid of passing a screw right down into the calcaneus. And I could correct the deformity, and look at this place where I have pushed in a lot of bone grafts. I made this raw. And so this hole has formed the ankle, and it has gone into the right axis of the ankle. And I could correct the deformity. Comments?
Very nicely done. So again, you see, until you play around with the foot, we don't know whether how much reduction you can get in. Acute reduction is possible, and you were able to do that and stabilize it. I think patient will do very well.
So,
Wonderful.
yeah, most often than not, whenever a cora is falling at the level of joint, we try to do osteotomy above the joint. We try to run away from the joint. So why can't we do reverse? That was the thought process in this case, that when the cora is above the joint, why can't we do osteotomy at the level of the joint? And the same osteotomy helps us for the fusion. And with this thought process, the whole case was done.
Before you go there, Rajiv, I'm
Please.
just going to have to. I'm going to have to sign off because it's very late for me. But
Yeah.
I'm very grateful and very thankful for you for being involved, and it's been really good learning experience for me.
Thank you very much, Mark.
So I hope to see you again soon.
Yeah, and very good night to you.
Yes.
Thank you so much. Thank you for accepting
Thank you,
my
Mark. Thank you
I'm
very
so
much.
grateful to you. And it's really so late at night. You're still with us. Thank you so much being with us. We learned so much from you, and we learned so much from your presentation as usual. Thank you so much.
No worries. I hope we can meet in person soon.
Yeah, thank
Take
you.
care. Bye-bye.
Well, quick, because Professor Panchbhavi is also early in the morning. He has to move with his breakfast and routine. I'll quickly finish with 4 or 5 cases. Should I?
Yes,
Sure,
please.
sure.
Sure.
Yes.
So a 52 years old male was sent to us after 2 years of trauma. He had a compound injury. He underwent multiple procedures. He came with a talus malunion. Infection was under control. And then when we went in, we ended up doing complete excision of talus. And then the question was how to bridge the defect when you're doing a TTC fusion and whole talus gets lost. How would you like to bridge defect, Professor Panchbhavi, sir?
You could, I mean, here we can get a femur, head of the femur, and we ream it, and that procedure has been described very well, and use as a bone graft. You know, if the, but having said that, you see, you know, it's rare for me to see the head and neck of the talus become avascular, even in the fracture. But I presume this was infected, and you had to sacrifice in the entire talus. But you know, that's what I would do. And you see the scenario also play out in patients who had total ankle replacements, wherein the implants got infected, and you remove that, and you put in a bulk allograft, such as a femur head or a humeral head, prepare it nicely. But sometimes they get infected, it's a disaster. But you can restore the height with a bone bulk allograft. And again, the preparation of those joints, joint surface is very important. You have to open up that nice channel at the distal end of the tibia, and also bring in some vascularity from the calcaneus. It takes a long time for that avascular bulk allograft to incorporate into the bone, and requires a lot of stability for a long time.
Yeah, the problem with us is that we do not have that an easy access to this. And also we are little worried about the sterility of the material which we are getting. So in view of that, we have developed a technique where we put in the fibular stud grafts. It has been described that 1 or 2 or 3 such grafts can be kept around the nail. But the problem we noticed that when we keep such a graft, in spite of putting a good nail, this graft sometimes get dislodged over a period of time. And so what we have developed a technique which we have labeled as a bamboo hut technique, where like a bamboo hut which is created out of the bamboos which are woven with the thread, or with the they are tied together to make it more stable. The similar kind of construct is what we're doing, where We're putting the grafts at 3 o'clock, 6 o'clock, and 9 o'clock, 3 stud graft, and then we tie it with the thread like this. So this is a defect, and you keep it distracted with the laminar spreader, and the nail is in, and then you keep in the grafts and tie it with the fiber wire, and then we have a straight nail through which we can do compression at the level of ankle joint, at the level of subtalar joint. So compress the nail, and thereby you can keep the grafts in the place, and it goes on to consolidation. And this is what was done in this case. So in the absence of allografts, TTC fusion can be done with a bamboo hut technique, where you're putting 3 fibular stud grafts all around the nail, and then also filling the area with the grafts from fibula to make a solid construct. We don't have any study whether it unites quicker than the allograft, but this is what we have been doing. Professor Panchbhavi, sir.
Yeah, looks good. I mean, obviously, you are. I think you, in addition to those fibular studs, have you put any cancellous chips in there? Yes.
Cancellous chips from the fibula.
Yes.
Because we go high to harvest the fibula. The lower part of the fibula, which is put back, the half of that fibula is cut, and then the grafts are put in, whatever grafts are available.
Yeah, I think, and fibular stud probably provides a lot more rigidity, more stability than a cancellous femoral head. I've seen femoral heads collapse. But I mean, you brought in a new technique, preventing the fibular studs to, preventing from them getting dislodged by putting those wires. Are you preparing those wires ahead of time and then putting those inside? Okay. Okay.
Yeah. So wires are going around the graft, and then the threads come. Then it goes around the graft, and then you tie it all together. Nice.
Yes, I think the biggest advantage is it does not collapse, unlike a cancellous graft. A fibula strut graft has a cortical strut, so it acts as an internal nail as well across the surfaces, and allows those cancellous chips to get reabsorbed into the bone.
What suture material do you use, sir? What suture material do you use?
Fiber wire.
Okay.
This is a male of 23 years who came with pain and restriction of ankle and subtalar joint movements from over 2 years. He is very stiff, not able to carry out activities of daily living, no other positive history. And these are his x-rays. Dr. Vora, EP and lateral x-ray of ankle, what do you infer from this x-rays?
The dome is flattened, and we look at avascular necrosis of the talus, and to me in this case.
Okay, so this is the avascular necrosis of talus in a young patient of 2 years. And what would you do? What next for you?
Me, it's the same again. First of all, I want to quantify how much of the graft I will be needing. Yeah. So it's virtually you have now neck with you, and the whole of the body is gonna go. So when I open, so what I've been doing is I've been using a fibular graft, which I showed in one of the cases, a combination of the fibular graft and a corticocancellous graft to fill this defect. The fibula is used as an intramedullary nail, and then you put all around that fibula the cortical graft taken from the sides, and do a plate from the large side. This is what I do.
Panchbhavi, sir?
Yeah, I think I've shown a similar case wherein this particular body was replaced by cement. And the video of the girl walking, you can't even see whether which side was nailed, you see, just like Rajiv Shah's videos. I looked at that vascular head of the talus, and I look at the vascularity in the distal tibial plafond, I want to make sure that the foot is subluxed behind so that we can at least have union there. And I don't discard that avascular body because I'm using it as a graft. You see, once you remove the articular cartilage at the distal plafond and also from the subtalar joint, you bring in blood supply both from calcaneus and also the tibia. So that's what I would do. I would put a nail in this particular patient with extra stabilization if necessary, but I want to make sure that I push the foot back so as to get the vascular aspect of the distal tibia to unite with the vascular head.
But then would you not do total ankle replacement with subtalar fusion in this case?
No. I mean, I think the body is avascular. For total ankle replacement, you want some vascular structure to put our implant, you see. So I don't know if anybody else does that, but you know, as far as I'm concerned, it's a young boy, right? You said it's 24 or something?
24, yeah. And so
24, yeah.
he's
And
not keen on getting fusion done.
I know, I mean, you know, I think really if you could do, I mean, a fancy total tailor replacement and that kind of stuff, but there are not many papers or longevity studies there, you see. So we don't know how they will turn out in years to come, but maybe you can get few years out of this if the patient is refusing and willing to try these new things. Certainly one can use it, but we don't know the long-term studies at this stage. But you know, you are a pioneer, and we can certainly use
the studies from the Eastern literature, sir, onto custom-made tailor processes. They have shown survival rate up to 30 to 35 years. Yes, but the 3D printed total talus replacement survivorship is quite, early to comment. But for this patient, I thought of going ahead with 3D printed total talus replacement, anterior approach, and this is how the osteotomy of talus was done, and all those material removed and implant loaded, pushed in, and this is how it set in. And this is the movement at the end of 3 months. Full inversion, full eversion, almost full dorsiflexion, full plantar flexion. And that's at the end of 3 months that he has started doing all activities except sports. So 3D printed talus replacement do need a consideration with discussion, open-ended discussion with the patient, where you are thinking to salvage both the joints.
Sir, just a question, sir. How many years of follow-up you have in this case, sir?
This is just 3 months, so 3 to 4 months. This is just 4 months. This is 4 months.
But
so long-term follow-up.
You have done such cases earlier also, no? You have replaced that talus earlier also.
I have replaced a talus, total talus replacement I've done for trauma. This is for avascular process. Yeah.
Yes.
Yeah.
Yes.
Okay. And I don't think I'll rush through this case. This is for the delegates. A 40 years old diabetic lady had a fall and left ankle fracture. And this fracture was treated like this by foot and ankle surgeon. And Shantanu, any comment on this fixation?
Can we go to the pre-op picture, sir?
Yes.
Yes, right. Please come to the post-op picture, sir.
Please.
It's a very unstable fixation. The reason being, if you look at the pre-op X-rays, you see there's a big posterior malular, well, not even, I don't want to say big, or there is a posterior malular fragment.
I would always, that is what I was going to say, sir. I would always, for such cases, get a CT scan done. Because even in X-ray, the posterior malleolus is always there. So they have just forgotten about this thing. So of course, a CT is very important, but if I have to comment on X-ray, that plate has to be put from posterior to anterior. So posterior malleus has been missed altogether in this case.
Yeah. So Professor Panchbhavi, sir, 40 years old lady, and if she says that she has a neuropathy, would you go ahead and do this fixation plus a posterior plate, or you would do something else?
If she is very neuropathic, she's been walking on it. I won't hesitate these days to put a nail in this kind of patients. If the patient is still feeling the pain, I would do ankle fracture fixation, but robust fixation with multiple screws in different directions. Again, depends on how long the patient has diabetes. We got dense neuropathy. If you're thinking
20
that
years
patient,
of diabetes.
yeah, if you got 20 years plus with no sensation up to mid leg, then yes, I would not hesitate putting a nail.
Dr. Vora?
Yes, it's a similar view as far as Dr. Panchbabi is concerned. I don't mind putting a nail into patients if they are absolutely neuropathic in this. But if they are not, then definitely I would like to preserve with the protibial screws, which you need a good fixation. Then you need to go from the back. You have to put the posterior malleolus back in these cases. So it's an extra fixation with the protibial screws, and that's a good rigid fixation.
So is there any objective literature guiding you, Dr. Vora, for a fixation or a fusion in a diabetic?
In the diabetics, there are I don't remember exactly, but I have gone through where there is you want to go for one go surgery in the patients with a neuropathy, you can go ahead with the nail.
So this is how she presented to me at the end of 4 weeks, where it was a neuropathic patient, failing fracture at the end of 4 weeks. And so I went in, and this is what I did: TTC nail assisted TTC fusion, and it went on to unite. The question is that, is there any objective evidence? Yes, this is Adelaide fractures in diabetic ankles, AFDS score, which I have followed very closely in my practice. So there are 2 points each for peripheral neuropathy, vasculopathy, previous history of Charcot, insulin-dependent diabetes mellitus, or poor control of HbA1c, which is more than 7.5, versus 1 point each for diabetes of more than 20 years, neuropathy, retinopathy, obesity, and non-compliant patient. And this, when you have a score of less than 5, you go for primary ORIF. That is what they've suggested. Score of 5 or above, you go for primary fusion. And in this patient, peripheral neuropathy, score was 2, HbA1c was 10, score was 2, neuropathy, nephropathy, she was on dialysis 1, and obesity 1. So score of 6 with a failing fracture. So I went in and did the fusion. Dr. Panchbhavi sir, are you following this score?
I'm not familiar with this score really. I look at the patient, and if I know she's not going to be compliant, obese patients, dense neuropathy, I lean heavily towards putting the arthrodesis nail. In a young, thin patient, who has some pain, who will be compliant, then I'm thinking of preserving the joints where I can. So, I go by case. I'm not familiar with that scoring system.
Yeah,
but,
so
if you have a scoring system and then follow it up and provide evidence in objectively based.
Yeah. So the message is that diabetic trauma infusions are a different ball game. And let me just sum up with this last case quickly. Female 67, known case of steroid-dependent rheumatoid arthritis with other comorbidities, had a non-healing plantar ulcer of 1 year, multiple treatments tried, failed, and this is how the ulcer looked like. It was draining. this was the X-ray, rheumatoid arthritis, and she was advised amputation by all. Dr. Vora, would you like to salvage the limb or would you go ahead with amputation?
Salvage.
Salvage?
Yes.
Yeah. What would you do?
We need to offload the part, the pressure point, by giving some kind of arthrosis and proper dressing. So it has been seen many a times when that part is offloaded, it can heal nicely. So once that heals, then we can think of doing some kind of arthrodesis in this case. I'll definitely like to save this limb.
Okay. So what kind of arthrodesis would you do?
Sir, I'll instead of plate, I'll try to
Your
put it in.
ulcer would heal with the offloading. That is what you feel.
Yes.
Now, mind you, this is not neuropathy. This is rheumatoid arthritis.
Yes, true.
Okay. And what kind of fusion would you do?
I'll probably use a TTC nail.
Okay. From the infected area?
No. I'll before putting in the nail, the first priority for me would be to somehow get rid of the infection, and then only I'll put the nail through that area.
Dr. Vora, your thoughts on this case?
First thing is, of course, to get rid of the infection. And once you have, once you're getting rid of the infection, you see how much bone you have to actually take it off. It is only at that, after that, the first operation of debriding, removing, and how much bone is left, the next decision is to be given to the patient.
Okay. So you're not for amputation?
Maybe, sir. I'm saying if there's nothing left after that, I don't mind. I'm a big fan of BK amputations, where I find we at our institute have a lot of plastic surgeons, and I see patients doing a lot of flaps, and after that they are going very slowly in their life for 5 years, 6 years, and they cannot earn. They may have saved their limb, but they have ruined their family, their life, when they are economically dependent on patients. I don't mind even going for BK amputation. To me, it's not a bad operation. I still try to convince but in this case, of course, if I find there is nothing left, I would go ahead with the BK amputation. No problem. It's a diabetic, rheumatoid patient.
Yeah. Panchbhavi, sir.
Yeah, I mean, there are quite a few problems going on. And obviously, she probably is on a medication and DMR, ADs, and other issues which will not allow good healing for her, whatever you do. If you look at the joints and what is left of the calcaneus, you have to understand where the pain is coming from. And it's probably going to be very difficult. Is it coming from the ankle? Is it coming from the Chopard's joint? Is it coming from those bony prominences, and on top of that, she has got a sinus, which looks, I don't know how far up it is going, you see. So these are very challenging cases, and I certainly don't mind, and I always give that option to them of that BKA option. Salvage is going to be challenging. She's not going to be pain-free. You can certainly do a limited debridement, make sure that you get the sinus healed. And then if she has some localized pain, which is, you can see the ankle is completely gone there and destroyed, you can try and achieve some fusion there if that is the main issue for her. But obviously you need to ensure that the infection is completely under control. And, you might need to stop the medication if she is on any DMRDs. DMRDs, yes. Not an easy. I mean, she may come back. Okay, so you got rid of the pain in the ankle. She may have a pain in this Chopard's joint. The fusion of the ankle may actually increase the stresses in the Chopard's joint and the Lisfranc joint. You can see there's no cartilage left there either. So these are difficult scenarios. You cannot give them satisfaction. You have to talk to the patient to see what exactly they want. Some people are happy to live their life with a sinus and some footwear modification. But overall, getting this patient a pain-free limb is going to be extremely impossible.
Yeah, she was not keen on getting it amputated. She was moving in the wheelchair, and relatives wanted that we should try and salvage the limb. Some other why I took up that challenge. So stage one, I went in Genslin's midline hill splitting approach. We did debride, removed all the dirty tissues, packed it with the antibiotic impregnated cement granules.
Plan.
And then in second stage, I went in with an anterior approach and I fused. I did the pentellar fusion and I bent the plate at 90 degree and fixed and did the fusion of the ankle and all other joints which were arthritic. And this was the second stage fixation at the end of 6 weeks. And she went on to heal and has gone back. She is walking. Obviously, there is a cushioned process, cushioned footwear which she is using, but her limb is salvaged. It's now 1 year post this fixation. So, uh,
Very nice.
yeah. So, and we have time for the last case, which is an incomplete case, but I just thought that it will be a case which I can fire at all of you.
Sure.
We already fired, sir.
Sure, sure.
So, this is the last case. Uh, so female 49 had pain in left foot. She had inability to walk even with ankle foot orthosis and had undergone some surgery in the past. You can see the scar over here and there are no records. So, and she had unilateral neuropathy. So the side, left side, she has neuropathy. So the left side where you see the wounds, some surgery was done in the past and she had neuropathy, and this is how this surgery was done. So Dr. Vora, looking at this x-rays and even these pictures, any thoughts what is going wrong in this patient?
It's a fixed in Aquinas. There's nothing. All you have to do is an osteotomy at the arthrodesis site and just correct in all planes. That is.
So, are you happy with the position of the heel?
No, not at all. That is in all planes. That's why I said it's not only the flexion. There's a valgus also.
So you're going to correct valgus
Yeah.
and procurvatum at
Yeah.
above the ankle.
Yeah.
By an osteotomy. So
Yep.
osteotomy in two plane.
Yeah.
But why is that this lady is having unilateral neuropathy on left side? Any reason?
There is hyperextension at the knee. I'm saying whether it's a compensatory to it or what it is. It is from you mean from the X-ray point. If I can make it out something the reason of the neuropathy.
Yeah, I mean, any guess why is that she's having neuropathy, tingling, numbness into
Iatrogenic, sir.
due to?
Iatrogenic due to injury to the anterior tibial nerve, maybe.
There is an anterior approach taken. Anterior tibial nerve will not give neuropathy. Professor Panchbhavi, sir?
How far up does her neuropathy go? Is it in a dermatomal pattern, or is it completely, like a?
It's not in a dermatomal pattern. It is more onto the plantar aspect.
Sir, one of our audience, Dr. Hitin Mathur, I am so grateful to him. He has been with us through this all 2.5 hours. He says that it may be due to tarsal tunnel syndrome.
Agreed.
Absolutely, Hitin.
Agreed.
Absolutely. So if you see,
because of valgus there.
Yeah, this is the way. No, now I'm coming to that. valgus plus something else. So this is the ways they used to walk. Obviously, there is hyperextension. And look at this screw.
Wow.
So Hitan, over and above valgus is something which was pushed in such a manner that it would have given this neuropathy. Now, Dr. Vora, this is what was done. Medial calcaneal slide osteotomy to correct the valgus.
And Aquinas was left as such.
Yeah,
Aquinas was left as such.
yeah.
So
So
probably it was getting compensated by the hyperextension, so you didn't touch it at the knee.
Professor
So I
Panchbhavi,
beg your pardon. My connection was lost for 1 minute. About 30 seconds, my connection was lost. So could you go a little bit and so I could also follow. The connection was lost for 30 seconds.
yeah, this is what the X-ray showed. Axial view. So the value of having multiple views is what I was trying to stress. The screw
Okay.
fully out, right? Okay, and this is what was done. Panchbhavi sir.
I'm kind of wondering as to why did you choose not to correct the equinus and the valgus at the same time? Obviously there are many ways to do this, but my preference would have been at that original level of ankle joint, wherein I could do both a biplanar osteotomy to correct both. That would have been my preference.
Yeah. Yes. So I later on realized that I should have gone at the same time. We should have gone with a anterior wedge removal osteotomy from the ankle arthrodesis side. But the only reason why I wanted to bring this case was just a reason that, from 2 X-rays, we feel that this patient, why should this patient have posterior tibial nerve involvement, which was because of this screw, which was put outside. So thank you very much, Dr. Vora. Your photo is here, but your photo is in my heart.
Oh, that's great, sir. So I need not put any photo now in any webinar. Actually, I want it only in your heart. It's already there.
So, Professor Panchbhavi sir, thank you very much.
Thank you,
For your time.
Rajiv Shah sir.
Yeah, just a minute. Whatever we have in Panchbhavi sir in India is solely because of a huge contribution of being mentor to us, all of us. Thank you, sir, for that.
You're so kind. Thank you.
Thank you, Vinod. Thank you very much. Have a good day. Have a good day.
Thank you, Dr. Vora.
Thank you.
Yes.
Before we yes, sir. Thank you, sir. Before we leave, there are many listeners, and among our audience, we have our very senior, very respected speaker. Audience, and our other figure to us all, Dr. S.S. Jha sir. He is there. He has been there since 5 p.m. and he is still there. I take this opportunity to thank him as well. I also have Hitin Mathur from Delhi, who has followed this webinar right from the start. So these are the audiences. These are the august foot and ankle surgeons who make our humble effort worth taking. So thank you to all my listeners, audience. And thank you, sir. First of all, I'll thank Panchbhavi sir, who from such a morning, yesterday, he had a long surgery list, he told me. And today, since 6 o'clock, he is there with us, sir. We are so very grateful to you, sir. We have learned so much from you, sir. Thank you so much for being here.
Thank you, Vinod. Thank you very much.
Yeah, what to talk of Rajiv Shah, sir? I think you are a magician. The cases you have shown, it was a tremendous, yes, sir, tremendous opportunity for me to learn. Somebody as fledgling as me, I learn a lot. And the opening batsman, Rajiv Vora, sir, you were really excellent all throughout the webinar. I am so grateful that you have accepted my invitation even on a Sunday. I know that you don't like to be there on Sunday, but you are there today.
There's nothing like that. There's nothing. I'll be very happy to join again if you have something on Sunday.
Thank you.
Thank you very
Thank you
much
all
for
so
invitation.
much.
Thank you very much.
Thank you all
I take a note of that you are available. Thank you
Thank you.
for the opportunity.
Thank you, sir. Thank you very
Good
much.
night. Bye bye.
Good
Bye-bye.
night. Thank you, sir. Bye.